Next question.
Good to go,
A
sir.
40-year-old businessman.
So, hello everyone and good evening. Can you please let me know if my audio and video is good? So I'm just waiting for your comments in the chat box to see if my audio and video is good. Am I audible? Am I visible? Okay. Right. Okay. Okay. Arya, Anirudh Batra. Anirudh, I think Anirudh Batra, I think you had topped the previous exam, right? Not this one, the previous, right? Anirudh? Lakshmi Thadboina, I think Lakshmi, you had won the cash prize for answering well, I remember in the groups, right? Right. So, hello everyone and good evening. We'll have a very concise discussion of the 10 MCQs that were asked in the Monday midday quiz. So I think the question was relatively more factual because rheumatology is such a factual topic. A few questions, 2 or 3, slightly on the tougher side. Maybe you can say 4, okay, max. But other questions were pretty much answerable, is what I suppose. But in case you have not answered that well, please don't worry. There is always a chance to improve. And every exam makes you, I think, a better doctor as well, because you get to realize what are your deficiencies and what all you should be correcting, right? Let's quickly go into the questions one by one. Okay. The first question is something I have picked up directly from Harrison. This is an exact line given in the Harrison 21st edition. So the question is, which drug, when given to an anti-Rho positive mother whose prior infant developed congenital heart block, significantly reduces the chance that the subsequent fetuses will develop heart block? So something that most of you know is that when the mother is anti-Rho positive, anti-Rho also known as anti-SSA positive, there is a high chance that the child born to the mother may develop a congenital or a complete heart block, right? The infant might develop a complete heart block, which is a congenital heart block. Now, which drug can be given to such a mother to prevent the development of that, complication? Well, what do you think is the answer? So out of the options given below, you can see that all the options given below are drugs used in the management of systemic lupus erythematosus. But out of all this, the drug that is useful in this scenario is hydroxychloroquine. So hydroxychloroquine can prevent the development of complete heart block or congenital heart block in mothers who are anti-Rho positive. Another important MCQ point that you should know regarding hydroxychloroquine is, previously that they asked this question in NEET PG as well. See, the treatment of SLE depends on the severity, right? You've got mild, moderate, and severe. HCQ is one drug which is useful in all ranges of severity. That is, patients with mild disease, moderate disease, as well as severe disease also, you can give the patient hydroxychloroquine. Okay, I hope that is clear. Let us move on to the second question. Okay, so second question, choose the false statement about drug-induced lupus. Drug-induced lupus is always a hot topic for NEET PG exam. And drug-induced lupus is slightly unique in comparison to the systemic lupus erythematosus. So what is the first point? The first option says, has less female predilection than SLE. Now remember, in case of systemic lupus erythematosus, it has got a female to male ratio of 9:1. So this is a disease which is very much dominant in case of females. But in case of drug-induced SLE, again, females might slightly outnumber males, but the female predilection that SLE has, this sort of a ratio is not there in case of drug-induced lupus. So in that case, the first option saying it has less female predilection than SLE is a correct statement. And they're asking you to pick the false statement. So I'm not going to pick this answer. The second option says rarely involves kidney and brain. So we know that systemic lupus erythematosus, one of the important complications is renal involvement, and you can also have neurological involvement as well. Drug-induced lupus is again unique in that it rarely only involves the kidney and brain. Okay, so I'm not going to pick that as the answer. The third option says rarely associated with anti-dsDNA. Again, this is a correct statement. So anti-dsDNA is usually not seen in patients with drug-induced lupus. Remember, again, the first three lines are direct picks from the Harrison textbook. Okay, right. That is clear. And the last one, rarely associated with ANA. Now, if you read Harrison, the topic of drug-induced SLE starts off by saying that this is an ANA positive condition. So anti-nuclear antibody can be present in case of drug-induced lupus. Now, can you just tell me, let me ask you one additional question. Is drug-induced lupus reversible? Yes or no? Does it reverse on stopping the drug? We know that several drugs can cause drug-induced lupus erythematosus like procainamide, hydralazine, sulfonamide. So these drugs can cause, are they reversible? Yes, most of them are reversible. Once you stop the drug, within a few weeks to months, this can revert back to normal. No confusions here, right? So Farsana, Sriram, Anirudh Batra, okay, right. Okay, the third question, the most common venous manifestation of anti-phospholipid antibody syndrome. What are the options? Livedo reticularis, superficial thrombophlebitis, pulmonary embolism, and deep vein thrombosis. Well, let me first tell you that all the options given here, livedo reticularis, superficial thrombophlebitis, pulmonary embolism, deep vein thrombosis, all of them are venous manifestations of APLA syndrome. But again, if you look at Harrison, you will see that the most common venous manifestation here is going to be deep vein thrombosis. Deep vein thrombosis. So that is the correct answer. Let me ask one additional question here to all of you. Let me see who is going to answer this. Will it be Anusha, Anirudh, Amrit, Lakshmi? Who is going to answer this? Can you tell me one anti-Parkinsonian drug that can produce livedo reticularis as a side effect? Can you tell me one anti-Parkinsonian drug? It is anyone. Anyone can answer me. Just waiting for your answers. We'll wait for a couple of more seconds. Which is that drug? Which is that drug? It is amantadine. The drug is amantadine. Okay, amantadine. Okay, amantadine can produce. Right. So moving on to the, I think Amrit and Anirudh Batra, both of them have correctly answered. Coming to the fourth question, choose the false wrong match regarding autoantibodies in SLE. The first option says anti-Smith prevalence is 75%. Absolutely wrong. So the prevalence of anti-Smith is only 25%. Remember, anti-Smith is a very specific antibody for SLE. However, anti-Smith is only seen in 25% of patients with SLE. Second option, anti-C1q correlates with the activity of nephritis. Now, this is one new antibody that has, come to the forefront in the autoantibodies in SLE. It was not there in the previous Harrison edition, but it is there now. So anti-C1q is an antibody which correlates with the activity of nephritis. Now, you've got to be a bit cautious here. Can you tell me the presence of which autoantibody confers a decreased risk of nephritis? Suppose if the question is which antibody confers a decreased risk of nephritis, it is what? Anti-Rho and anti-La. Anti-Rho and anti-La. But C1q positivity means there is an increased risk of nephritis. Okay, increased risk of nephritis. And which is the autoantibody that is helpful in the overall assessment of disease severity? It is anti-dsDNA. Overall assessment of disease severity, anti-dsDNA. So this one is a correct match. Anti-histone drug-induced SLE is again a correct match. Anti-neuronal antibodies are associated with active CNS lupus is also a correct match. So they're asking for the wrong match here, which will be option A, right? Okay, right. Next is all the following are clinical features of systemic lupus erythematosus except. So recurrent abortions, sterility, Coombs positive hemolytic anemia, and psychosis. So if you look at the options here, you know that systemic lupus erythematosus is a multi-system disease. Okay. So first option, recurrent abortion. Can SLE have recurrent abortion? Yes. SLE is in fact the most common cause of a secondary APLA syndrome. So SLE is often associated with secondary APLA syndrome, and this can lead on to abortions. And do you know what? Sometimes, rarely, SLE per se also can lead on to abortions. So the first statement, it is a clinical feature of SLE. And in the hematological manifestations, what sort of anemia does SLE patients commonly have? They commonly have got the normocytic normochromic anemia, but they can also sometimes have the Coombs positive hemolytic anemia. So this is also a manifestation. Okay. Can SLE patients have psychosis? Yes, it is one of the neurological manifestations. But remember, sterility is not a feature of SLE. It does not affect the fertility, neither in males nor in females. It does not affect the fertility. Again, a very important line that is mentioned in Harrison. So the answer is going to be option B, sterility. Okay, so yeah. So some of the questions I've put here, directly I've handpicked from Harrison because I want my students to be prepared for a range of questions. I always tell my students, when you prepare for competitive entrance exams, you've got to have a sufficient range of knowledge. So even if some questions turn out to be factual, you should be able to answer it. Even if the questions turn out to be clinical, you should be able to answer it. So you've got to have that sufficient range. Next question, all the following are part of the 2019 ACR EULAR diagnostic criteria for SLE except. So remember, I've told you for SLE, currently the most preferred criteria is the 2019 criteria of the American College of Rheumatology and European League Against Rheumatism. That is a 2019 ACR EULAR criteria. Now, here, this you have got to know very thoroughly. Now, if you look at this criteria here, okay, so I think, I'll just take the next question also and discuss this criteria, at once, because the next question is also based on the criteria. So the next question asks you obligatory entry criterion for the 2019 ACR EULAR classification for SLE. So look at this. In the 2019 ACR EULAR criteria, first of all, for a patient to actually qualify to be considered in that criteria, there is an entry criterion. And what is an entry criterion? The anti-nuclear antibody should be positive. So ANA titer has to be there. In what amount? ANA titer has to be above 1/80. So if a patient does not have a positive ANA, in fact, a titer more than 1/80, you cannot actually consider the patient for this criteria. Understood? Now, if you look at this criteria, I'm not going into detail about the criteria. As I said, this is just a concise discussion session. Now, if you look at the options, number one, autoimmune hemolytic anemia. Look at the hematological manifestations. You are seeing that autoimmune hemolysis is a part of it. Next option, you look at photosensitivity. Again, photosensitivity, if you look at this, mucocutaneous manifestations. Did you see this? In mucocutaneous manifestations, are you able to see acute cutaneous lupus? And what are the acute cutaneous manifestations? You've got photosensitivity as well as malar rash. Photosensitivity as well as malar rash. So photosensitivity is in fact a part. So I'm going to cut this one as well. Okay. What about serositis? Yes, serosal involvement, pleural effusion, pericardial effusion, pericarditis, they can be considered. So that is also a manifestation. But did you see this? They are not considering Lippmann-Sachs endocarditis. Definitely, Liebman-Sachs endocarditis is a manifestation of SLE, but I'm saying that this is not a part of the diagnostic criteria per se. So this is option B, that is the answer. Okay. And what about next question? What is the obligatory entry criterion? Is it anti-dsDNA, anti-Smith, low C3 or positive ANA? It is positive ANA. And to be more correct, I would say that ANA titer more than 1/80. Okay. So that is question number 7. Question number 8. In a pregnant woman with a history of recurrent abortions. Now, you've got to read the question carefully here because you're likely to be confused. Okay. So, history of recurrent abortions, and the patient is already having a diagnosis of APLA syndrome. Now, the patient is pregnant. So, what should be the ideal strategy in the current pregnancy so that the patient does not develop a abortion? She has got abortion history previously. What can she do? So this, you can see two options starts with therapeutic dose of LMWH and two options starts with prophylactic dose of LMWH. Please understand, you give therapeutic dose of LMWH, which is a higher dose, only when the patient is having abortion in the current pregnancy. Okay, in the current pregnancy, if there is a an event, an abortion, then you will give therapeutic dose. But here, the patient is not having an event now. It was actually a history of recurrent abortions. So I am going to eliminate these two options. So I'm clear that this is something regarding prophylactic use of low molecular weight heparin. Now we know that pregnancy is precious, and when something is very precious, you need added protection. So you will add low dose aspirin as well. Now, at least a few students would have been confused. Should I go for steroids or not? Now, generally, remember, not just pregnancy, APLA syndrome, generally, you don't go for steroids, except in refractory cases. So generally, you don't go for steroids. Okay, generally, you don't go for steroids, especially in pregnancy. You don't go for steroids as such. So only in certain exceptional circumstances, usually out of pregnancy and patient having recurrent thrombotic episodes, then you may consider adding steroids, especially when this APLA syndrome is associated with SLE. So if it was mentioned in the question, something like APLA syndrome, patient also having features of SLE, then yes. Okay, right. Somebody is asking, Raghav Pandya is asking, is aspirin 75 milligram? Yes, Raghav Pandya, it is 75 milligram. Okay, right. So what is going to be the answer here? The answer is going to be option D, prophylactic dose of LMWH and low dose aspirin. Now, question number 9, again, direct pick from Harrison. See, again, I want to tell all my dear students, if there is somebody who is feeling that, oh, sir, I missed out on a few questions, I do not know this, that's fine. See, on purpose, I've given you some good questions from Harrison also. I want my students to prepare for the exam, be it NEET PG or INICT with a good range. Okay, so that, however twisted the question is, you will be able to answer. Okay, right. So choose the true statement regarding antibodies in APLA syndrome. The first one, antibodies against beta-2 GP1 can be detected by ELISA. This is a true statement. Okay, this is a true statement. The next one, IgM antibodies. So when you've got these antibodies in the serum, IgM antibodies confers higher risk compared to IgG. Okay, apparently this looks good, but that is wrong. It is actually the IgG which confers higher risk compared to IgM. So the APLA antibodies, when you get the IgG antibodies, they are actually having a higher risk compared to IgM. Did you understand? Then the next one, lupus anticoagulant causes prolongation of clotting time in vitro, which is corrected by adding normal plasma. So you know that in vitro, lupus anticoagulant can prolong the clotting time, because I have taught you that there is APTT prolongation, no doubt about it. Now, is it corrected by adding normal plasma or not? Answer is, it is not corrected. Now, this is important because, when you want to differentiate between, say, a clotting factor deficiency producing some sort of, bleeding disorder versus lupus anticoagulant. See, when there is a clotting factor deficiency, if you add normal plasma to it, the normal plasma would contain the clotting factors. So that means all the clotting time that was prolonged would be corrected on adding normal plasma. But in lupus anticoagulant, since that antibody is present there, even if you add normal plasma, this antibody will again cause prolongation of the clotting time. So remember, here it is not going to be corrected by adding normal plasma because the antibodies are always there. So this is also wrong. So what is going to be the answer here? Answer is option A. Antibodies against beta-2-GP1 are detected by ELISA. That is also clear? Fantastic. Coming to the last question, not a predisposing factor leading to SLE. So I've taught this in my lectures as well. TREX1 gene mutation, yes, TREX1 located on the X chromosome is a predisposing factor. So I'm not going to go for this in this option. Option B, Epstein-Barr virus infection. Well, here again, I know that this is a risk factor. Again, sorry, I'm just going to cut it off. HLA-DR3, again, HLA-DR2, HLA-DR3, and HLA-B8. HLA-DR2, HLA-DR3, and HLA-B8, they also increase the risk of SLE. So I am going to cut this option as well. What is the last option? Deficiency of late components of complement. Is this correct or wrong? It is wrong. It is not late complement deficiency. It is early complement deficiency. For example, C1q, C2, C4. Okay, C1q, C2, C4. If those complements are deficient, then that would be a predisposing factor leading to systemic lupus erythematosus. Okay, so I hope that is very clear for you. Okay, so thank you so much everyone for joining this session. This was a very short discussion of the Monday midday quiz. I hope you keep on attending the Monday midday quiz, which happens every Monday on a very short topic of medicine, which gives you an opportunity to study that topic in depth and attend the exam. Well, in every exam, I put a few questions which are tough. Obviously, that should happen, right, for every exam. So do not worry if you have got a few questions wrong, but please take it as an opportunity to correct yourself. And if there are extra points in this session, please add them to your notes. So thank you so much, everyone, for joining, and stay tuned for the other Monday midday sessions coming up. Okay, thank you so much, everyone, for joining, and good night. Thank you so much.